Pediatric sialoendoscopy begins with selection of the appropriate equipment. It is important to have specialized endoscopes available to perform sialoendoscopy. There are two main sizes available for use in the pediatric population, the 0.8 mm and the 1.1 mm scope. The 0.8 mm scope is useful for diagnostic purposes only and is best in cases of stenosis or when simple lavage is needed. We find the 1.1 mm scope to be the most useful, as it can be useful for therapeutic purposes. A 1.6 mm scope is available, which will allow one use of grasping and biopsy forceps. However, this is too large for the pediatric population. The scope size is indicated near the hub, and there are 3 ports on the opposite end. In addition to the light source, the scope allows for irrigation as indicated by the raindrops. The middle port serves as a working channel, allowing for use of instrumentation. Prior to introducing the scope, the salivary gland papilla is cannulated and dilated. The papilla should be dilated to a size that accommodates the endoscope. It may be helpful to use a bite block, mouth gag, or other retractor to gain better access to the papilla. Keep in mind that nasotracheal intubation is likewise helpful for exposure. Once the papilla have been adequately dilated, the endoscope is atraumatically introduced. The end of the scope is meant to be somewhat flexible, but excess distortion of the scope should be avoided. Next, the scope is advanced within the lumen of the salivary duct. Continuous irrigation is used to prevent collapse of the duct. Here, note that this is a normal lumen with normal vasculature. Once a pathology has been identified, the necessary instrument is introduced through the working port. In this case, a sialolith is seen within the lumen of Wharton's duct. After locating the stone, the wire basket is introduced, advanced beyond the stone, deployed, and then withdrawn with the stone in place. If you find that the stone is too large, a papillotomy can be performed. Avoid the papillotomy in early stages of procedure, as this can interfere with visualization due to loss of irrigant and duct collapse. For other pathologies such as strictures or debris within the lumen of the duct, this system has capability for dilation and lavage respectively. Although there is a variety of instruments that can be used with this system, keep in mind that there are no instruments with a grasping function. Postoperative care is as follows. This is usually a same-day procedure in most cases. Routine antibiotics are usually not administered, and the patient is advised to maintain hydration and to use sialagogues to help with salivary flow.